there, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined today by Dr. Ben Thrower. He's going to attempt to answer, as usual, as many of your questions as he can in the next hour. We're so grateful for that. Now I'm delighted to introduce him. For anybody that doesn't know him, Dr. Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta, and he previously served as the medical director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the senior medical advisor for the Multiple Sclerosis Foundation and always contributes to their quarterly Focus magazine. Dr. Thrower, we're so pleased to have you with us, and once again, I'm going to give everyone some directions for those that haven't been with us and don't know how to put their questions in. If you have a question or comment, you can ask it by using the Q&A button in the app, which also allows you to send your question anonymously if you choose to. You can also ask your question by raising your hand, live by raising your hand. And to do so, you just click on the raise hand button or just press *9 if you're on the phone. I'll call on you, and of course, at that time, you'll have to unmute and ask your question. So I am going to say, let's start. Hold on.
Awesome.
I love
Very
this
good.
every other month stuff. Great. I do. I so look forward to this. I love the question. So here we go. We do have one in Q&A. After taking and this is from Gus, after taking Mavenclad and your lymphocytes come back, can you be more aggressive or cause a new autoimmune decrease?
So with Mavenclad, just to so everyone knows, so that drug works by lowering your lymphocytes. You take 2 doses, so a course now, a course a year later, and then in theory you're done. What it appears to do is reprogram your lymphocytes so that they come back in a less angry state, so that you would have less active inflammation. We really have not seen them come back in an angrier state. That was an issue with Lemtrada or alemtuzumab, where very effective drug that also works by lowering B and T cells. But what we saw in some people with Lemtrada is that there was some risk for B cell driven autoimmune conditions. So it appears that in some people, the B cells came back a little angry, whereas we've not seen that with Mavenclad, fortunately.
Oh, thank you. Shelley wants to know, my walking is just deteriorating without any new lesions. Is it just an organic thing?
So, this is a topic that we spend a lot of time talking about, because it's so important to so many people. And that's, why do we see some people getting worse when they're not having relapses and they're not having new lesions on MRI? And the term that we use to describe that is PIRA, P-I-R-A, progression independent of relapse activity. We think there are a lot of things that can drive that. Some of the more important causes could be loss of neural reserve, or just the brain and spinal cord's loss of ability to adapt to prior injuries. And then there's this newer concept of smoldering inflammation, or just very, very low level inflammation, maybe, low level enough that we're not picking it up on MRI, but enough to maybe drive some progression of symptoms. I think deconditioning in some people can play a role as well. So, a lot of us don't get the amount of exercise that we should. And if you're dealing with something like multiple sclerosis, the price that you pay for not being as active can be a little steeper than in someone without MS. So I'm a big believer when I see someone whose walking is getting worse, in definitely getting them as engaged as possible with physical therapy to see how much function we can improve upon.
Great. Jim says, primary progressive MS, Ocrevus versus Briumvi. Been on Ocrevus for many years and was informed today they might want to switch, yet I don't know. I don't see it for PPMS.
So Briumvi and Ocrevus are both anti-CD20 monoclonal antibodies. We would put Rituxan and Kesimpta in with that same group. So all these drugs basically have the same mechanism of action. Of those, Ocrevus is technically the only one that is FDA approved for primary progressive MS. Doesn't mean the others couldn't work. There's just not data out there to say that. I would expect that there might be a response. I think the most practical limitation for someone in that situation switching to Briumvi is I suspect the insurance company is going to scream and yell and really fight that because it is off-label. The Briumvi, is not FDA approved for primary progressive MS.
We did receive a question from Angel via email, and they said, I'm 61. I was diagnosed with MS 30 years ago and have been on Rebif for over 20 years. I almost never get sick, but this year I've already gotten the flu, which I haven't had in 35 years, and a respiratory infection. Could it be because at my age, my immune system is calming down and I no longer need Rebif to modulate or lower my immune system? Should I stop Rebif to keep my immune system strong? Should I inject only once a week instead of 3? Is it okay to suddenly stop Rebif after so many years? My MRIs are stable.
Yeah, those are all great questions. So I don't think the Rebif or the interferon therapy would be the cause of the infections. If anything, you could argue that interferons like Rebif have some antiviral properties, but her other thought she's getting older, that her immune system may be calming down could be exactly right. So we call that immune senescence, and we all do it. As we get older, our immune systems kind of mellow out. A little bit of immune senescence in a person with MS could be a good thing. It could mean that there's a point where you don't need to be on your disease modifying therapy. There was the DISCO MS study, the discontinuation MS study, that looked at this, and it mainly looked at people like this individual who were on platform therapies, Copaxone or glatiramer, interferons like Rebif, and they randomized these folks to either stay on their treatment or go off. And these were people who had been stable, no relapses, no new MRI lesions. And at the end of 2 years, there really wasn't a great difference between the two groups. There might have been a slight trend towards more MRI lesions in the group that went off treatment. I would say from our personal experience, we have a large number of individuals that we've had discussions with over this situation. Can we safely discontinue a drug like Rebif in someone who's 61 years of age, and a lot of our folks have made the decision to go off, and I would say we've been generally pretty happy in most of these individuals. We've not seen any new stuff going on. There's no need to necessarily taper a drug like Rebif. You certainly could say, well, I want to do it in baby steps. I'm going to lower the dose. If you did Rebif once a week, you're basically almost on Avonex. So, Avonex is interferon beta 1A, 30 micrograms once a week. If you did your Rebif shot once a week, assuming she's on 44 micrograms, you're kind of on Avonex at that point. So if she wanted to kind of do it in stages, there's nothing wrong with doing it that way either, just to take it down in notches and not go all at once. But there's no withdrawal effect if she were to abruptly stop the Rebif.
Thank you. Another email came in from Sue, and she said, I do not have problems speaking other than needing to clear my throat often. But when I sing, like in the quartet I'm a member of, my voice is often shaky and difficult to control. Could this be caused from MS, or should I look for another answer?
I would definitely have her see a speech language pathologist. So really the two things, the needing to clear the throat, could be an indication of just a little bit of mild underlying swallowing dysfunction. In some people that are asking a lot of their voice, like singing in a choir, we can see something called spastic dysphonia, where the more they ask of their voice, the more difficult it gets. And that can act up in a lot of ways. And some people, the voice gets kind of quiet, whispery, or raspy the more they use their voice, and other people it may take on different sort of intonations, like a sort of a warbly or kind of wavering sound. So I would definitely touch bases with a speech language pathologist. That there's a decent chance that's related to her MS.
Great, I'll let her know. Please talk about new research that just came out regarding the regenerating of myelin in mice. That's from Alyssa.
Yeah, so that was a team that looked at some proteins that had to do with something called histone that's attached to DNA that may give us some more clues as to why oligodendrocytes, the cells that make myelin, are not doing as good of a job. We know as humans we can make new myelin. Why don't, and we have these things in our brain and spinal cord called OPCs, oligodendrocyte precursor cells, that are cells that want to become oligodendrocytes and make myelin, but something needs to turn them on. Why aren't we using those cells in people with MS? Why aren't the oligodendrocytes repairing myelin? So this mouse study, is one step in the direction of solving that mystery. We always have to, we're excited when we see breakthroughs like this. We always have to temper that excitement and realize it is the mouse model, and we have had numerous examples of things that looked very promising in that mouse that didn't translate necessarily into humans, but it certainly is a step in the right direction.
Thank you. Mike said he's been diagnosed within the past year and a half and hasn't done any DMT just yet. Reading up and hearing some feedbacks, difficult decision on what's best. So far, walking impacted the most, along with maybe digestion. Anything? Can you talk about side effects?
So, we have lots and lots of choices out there now. We back in the day, we had ABC, 3 choices, and now we have, if you count generics and biosimilars, we probably have 27 different choices. I think what the person who's making that choice for themselves, the person living with MS, I think you have to decide what is really important to you. Are you willing to tolerate some side effect risk? Are you really, would you be willing to go on something that is very, very effective, that maybe has a little bit more risk? Or do you have very little tolerance for side effect risk? Are you most interested in an IV medication or an oral medication? I would say most MS centers out there, we are probably biased towards wanting to see you on a highly effective therapy. What most of the research has said is the sooner we can jump on board with the treatment and the more effective that treatment is, the better the person's going to do in the long run. So personally, I feel like with the more effective therapies like the B cell therapies or natalizumab, I think that we can manage that risk. That we can pick one of those more effective therapies, find something that fits your lifestyle, and give you kind of the best of both worlds. Good safety profile, minimal side effects, and the best protection you can get. I'm not as excited about putting a newly diagnosed person these days on one of the older platform therapies. We just are not putting a lot of new people on the Rebifs and the Copaxones and the Betaserones and Avenexes. We do occasionally, but it's rare. I would be much more excited about seeing someone like that go on a more effective therapy.
Thank you. Any thoughts on PET scans for smoldering identification?
Yeah, so PET scans, I don't think it's going to be the magic bullet we're looking for towards finding smoldering inflammation. So smoldering inflammation, again, is this idea that if MS is a forest fire and we put the big fire out, that there are these little embers underneath the surface that are still driving some of that progression of symptoms. We think that immunologically, some of that smoldering inflammation is driven by cells called microglia, part of the immune system, and maybe by something called B cell follicles in the brain and spinal cord that are driving some of that low level inflammation. One of the clues to smoldering inflammation may actually be a more subtle MRI finding called slowly enlarging lesions. So these are MS lesions that are just getting a little bit bigger year after year. There may not be really active inflammation as measured by dye uptake. It's not a new lesion. Some of the newer MRI, techniques, so where we're using artificial intelligence-based programs, what AI is being shown to do is maybe be much better than the human eye at detecting those slowly enlarging lesions. So that may be one of the clues to this underlying kind of smoldering inflammation.
Wow, if you have smoldering MS, what DMT can you use?
Yeah, that's the million-dollar question. So we don't. So if smoldering inflammation really is driving someone's progression, we don't know that any of our existing DMTs address that. That is the hope behind this new class of drug, the BTK inhibitors, that there are 4 of those in development right now. We got bad news on one of them back in December. One of the BTK inhibitors did not meet its primary endpoint in showing that it was better than teriflunomide. But there's still a lot of research. There's still great hope that this class of drugs, which they work on B cells, but through a very different pathway than our current anti-CD20 monoclonal antibodies, so that they may address that smoldering inflammation. So fingers crossed.
Thanks. Is there any merit to the liquid gold, an alleged digestible MS symptom diffuser or eliminator? And was this was announced via Fox News April 29th? So,
Yeah, I saw, I think, yeah, I'm not quite ready to sign off on that yet. I saw the reports. Before we do these, I always kind of do a little literature search just to see what's the latest breaking thing. I have not seen anything published on that in a peer-reviewed article. So I would say let's stay tuned on that until we see something a little bit more. I mean, it sounded interesting, but I could not find any peer-review published paper on that yet.
and somebody said, I recently got colitis. I'm on Ocrevus. This was my second colitis. How can I avoid this?
So the B cell therapies like Ocrevus have been associated with some risk of colitis. So, my question back to the gastroenterologist is, do we have a better explanation? Some other medical condition, something else that's going on that we can hang our hat on and say, this is what's driving that person's colitis. It's not the Ocrevus. If we don't have a better explanation for the colitis, that could be a deal breaker for that person being on a B cell therapy. If it's a significant issue, it may prompt a change to a different class of drugs.
Thank you. Stephanie said she has relapse remitting MS for 11 years and she gets sick repeatedly throughout the winter and has been treated for chronic sinusitis several times. This is happening more often during the year. She can get dizzy when she has it. Her primary care provider says ask her neurologist. Her neurologist doesn't have an answer. She's been on Ocrevus for 2.5 years now. Any
I mean, so
suggestions?
one of the side effect risks of our B cell therapies, as much as we love this class of drugs, is a higher risk of upper respiratory infections. So we want to make sure that a drug like Ocrevus is affecting the immune system in the way we want it to, and not doing anything more. So when we look at our B cell therapy patients, we look at their absolute lymphocyte count. We want that to be normal. We're going to break that down into the B and the T cells. The B cell subset, the CD19, is what we're measuring on the lab assay. That should be 0 or very close to it. That's the way these drugs work. The T cell subsets on the other side of the ledger should be normal. And then we like to see the IgG levels, and maybe IgM can be checked as well. We like to see those in the normal or worse low normal range. If the T cell subsets, absolute lymphocyte count, or antibody levels are low, that could be an indication that we're pushing a little too hard with the Ocrevus. And then at some point the discussion may need to be had of, I know what we do, we sometimes lower the dose in those individuals. Some people would switch classes altogether and say, we can't have recurrent infections. We know that things like sinusitis are not great for a person's MS. People with MS who get upper respiratory infections, a lot of times they have pseudo exacerbations. Their symptoms get worse and they become less functional. So I would make sure that someone's monitoring the labs, maybe some thought to, if need be, to lowering the dose or even switching to a different class if those sinusitis are really, if they're becoming a problem.
Thank you. Tiffany's been diagnosed with relapse remitting MS, and she has had 2 Ocrevus infusions and in 3 weeks out from her 3rd infusion. In the past 8 weeks, she's been having new symptoms, including vertigo, increased pain, and the onset of problems with swallowing. The recent MRI was negative for any changes to the lesions. Is this indicative of smoldering MS, or is this an indication of a change to SPMS?
So, the presence of, if it's a a worsening of symptoms in the absence of new lesions or relapse, and that's kind of the definition of PIRA, this progression independent of relapse activity, and that could go along with smoldering inflammation. That's kind of what we think of. We always want to make sure there's not something else going on, an underlying infection. We have an algorithm at our center. When someone calls in with new or worsening symptoms, we're going to go through questions related to, is there an underlying urinary tract infection, a sinusitis? Is there something that's driving this that's going on? Given what she's describing, that that's a fairly quick change. I wouldn't want to change her label from relapsing remitting to secondary progressive based upon that quick of a change, but it certainly bears a little bit more investigating. And I think high on the list is ruling out any underlying infection that might be driving this. There's a silver lining to that. I mean, if you find a little UTI or upper respiratory infection, it says, okay, well, that explains why the person is not feeling great. It is frustrating when people living with MS get caught in this kind of punting back and forth between the neurologist and the primary care doctor, I feel badly when people get stuck in that cycle. But I think because there's a question, I mean, is it Ocrevus related? Is it infection related? Normally, at most MS centers, we would kind of own that, the neurologist and our team.
Thank you. And I know you just mentioned PIRA. Can you just go a little bit more into that, because somebody's asking you to discuss it?
Yeah, so PIRA, again, or PIRA, depending on how you pronounce it, PIRA, progression independent of relapse activity. So typically when we say PIRA, a lot of people jump automatically to the smoldering inflammation, which I think can be an explanation. So again, PIRA is you're getting worse and you're not having new lesions on MRI and you're not having definite relapse activity. So I think the smoldering inflammation is one potential explanation for that, but I do think loss of neural reserve, just how well our brain and spinal cord adapts to prior injury, can be another potential explanation for that. Right now, I don't know that we have a great way of distinguishing in a given individual, is it smoldering inflammation or is it loss of neural reserve? Maybe the presence of slowly enlarging lesions on MRI would point you more towards the smoldering inflammation. Again, that's still that's not always easy for the human eye to detect on MRI, and that's where we are counting a little bit more on these more quantitative MRI programs that are out there.
Thank you. Angela wants to know what you think about her flying to the Grand Caymans and getting stem cell treatment.
So I would say, like any big healthcare decision you're making, be a really smart healthcare consumer. So mesenchymal stem cells, when we say stem cells, there are really two topics. There's hematopoietic stem cell transplantation. That's basically the bone marrow transplant, where we're taking your stem cells off, using chemotherapy to shut the immune system down, giving you those cells back. And then there's more what she's describing, where you get mesenchymal stem cells. There are a lot of scammy places out there, and you just have to be very cautious. I don't know the center in the Grand Caymans in particular, but just really do your research. If a center is doing mesenchymal stem cell infusions, I would ask them to show you some kind of published peer-reviewed, information. If everything they're showing you is anecdotal testimonials, Bob had it and Bob said he did great. Well, ask if you can talk to Bob. We've had patients get burned. We've had individuals go down to Costa Rica, spend a lot of money, and a lot of times not have anything good come of it. Yeah, so you really do have to be cautious.
Somebody was diagnosed 40 years ago with what is now known as pediatric onset MS. Their MRI and symptoms have been stable for over a decade. Is it safe now to stop the DMT?
So the question is, are you stable because you were a very fortunate individual and you just were blessed to have a very mild form of MS, which we know does happen, or are you stable because of the DMT that you're on? I think that discussion about stopping DMTs is a lot easier in the 60, 65-year-old population where we're getting some data than it is in, a younger person. I'm very nervous about stopping DMTs, in someone who's doing well. The challenge is if you stop the DMT, and if the reason you're doing well is because of the DMT and you have a relapse, with every relapse in a person with MS, there's about a 30% chance that you're going to keep a new permanent symptom. So that's kind of the risk benefit discussion. I would really have an honest discussion with your healthcare team about, is there something about the DMT that is just not fun? Is there a financial burden? Is there a side effect? Is there a hassle factor? And if so, is there something we could do that would make that easier for you to stay on a DMT for the longer haul? So yeah, I would lean towards probably not stopping.
Thank you. Sherry says she's just so tired of being tired. Is there anything new out there that can help with that?
Yeah, so fatigue it's kind of ironic in that it is the number one symptom complaint for people with MS. It is, fatigue doesn't do the symptom justice because we all get tired, but the fatigue we see with MS is by definition, limiting. It keeps you from doing what you want to do. And the irony is that there is no FDA approved treatment for fatigue in MS. There's nothing new at this point. That doesn't mean we don't try lots of things. I mean, the spectrum of prescription medicines is everything from old school amantadine or Symetril, old anti-influenza drug, works in about 40% of people. Then you get into kind of modafinil and armodafinil, which is Provigil or Nuvigil, and then the true stimulant drugs, your Adderall, Ritalin type medications. We always want to look at the big picture with fatigue. We want to make sure that there's nothing else contributing to the fatigue. Underlying sleep disturbances, sleep disruption is very, very common in MS for lots of reasons. Maybe the person's having leg spasms at night, or they have to get up and go to the restroom every 30 minutes. And so if we can address those things and improve sleep, that's going to translate into better energy levels in the daytime. Underlying obstructive sleep apnea is way more common in the MS community than it is in the non-MS community. So we want to make sure we're not missing that, because that will definitely contribute to daytime fatigue. There are some over-the-counter supplements where there's some data. Acetylcarnitine is an oral supplement where there has been some data suggesting it might improve energy levels. There was a funny study last year with oral lavender capsules. I don't know what possessed someone to try lavender for fatigue, because we normally think of it for calming or sleep, but they did it as a morning dose, a 600 milligram oral lavender capsule, and it was a double-blind placebo-controlled trial, small but well-designed, and in about 40 to 50% of people got an energy boost from it. So lots of things to try.
Wow, that's cool. Okay.
Yeah.
I find this question very interesting, because I think of this often with when you have cancer and you have a oncologist taking care of you, or if you have what's the other thing that somebody else would, if you're not a if you're pregnant, you have a gynecologist taking care of you for months. So, but somebody's actually asking, if you have MS, shouldn't your neuro be your primary caregiver because you have MS? So in
No.
theory.
And I always joke, because if your neurologist is your primary care doctor, you have a bad primary care doctor. We want to be as comprehensive in your care as possible, but there are things, other health issues that are really outside of multiple sclerosis. I mean, there's routine health screening, for guys, prostate cancer, for women, mammograms and pap smears and things that your neurologist is just not going to be equipped to do. So we really do want you to have a good primary care doctor. You put a lot of time and effort into managing your MS. Do the preventative health things too, because at the end of the day, people don't die from MS. They die of heart disease, cancer, and stroke. And so we don't want to, have you put 110% of your focus on just your MS and then miss, getting a colonoscopy and have a colon cancer pop up. So no, you don't want your MS doc to be your primary care doc.
Great answer. Thank you.
Yeah.
After taking Mavenclad, at what month are lymphocytes the lowest? And is it necessary for your lymphocytes to drop below 1.0, either year 1 or year 2 to be successful?
Yeah, so they typically are going to hit their lowest, in somewhere in the 3 to 6 month range. There's a little bit, variability from person. So 3 to 6 months after that oral course of Mavenclad, and then they usually start kind of slowly coming back up towards, when you're due for your second round at year 2. I'm trying to think in the study, and I cannot recall specifically if there was a strong correlation between how low the lymphocyte counts dropped and the clinical effect. I honestly don't remember that from the study. I don't think there was a perfect correlation. Most people's lymphocyte counts are going to drop, at least some, but I don't know that it was absolutely necessary that they went below 1,000 to see the clinical effect.
How do you treat patients that aren't able to sleep? Who would you prescribe or recommend? Does Ocrevus cause insomnia?
The Ocrevus would not cause insomnia. Again, sleep issues are again very, very common in MS. You can see difficulty initiating sleep, difficulty maintaining sleep, both of those. We want to make sure that the symptoms are not the reason you're waking up frequently through the night. And if it's a spasm issue, a bladder issue, manage those to try to improve the sleep. A lot of times we will, do things to prescribe things ourselves. If we suspect that there is a significant underlying sleep issue, especially something like obstructive sleep apnea, that's where you want to get a sleep specialist involved. They might do an overnight sleep study, a polysomnogram, to see exactly what's going on. You don't want to miss obstructive sleep apnea because there are other health issues that can go along with that if you have years and years of untreated obstructive sleep apnea. We do prescribe things like Lunesta and Ambien, trazodone, old school antidepressant that can be used. One of the side effects of trazodone is it can make people drowsy. I like over-the-counter CBD for sleep. If someone just has a hard time turning their brain off at night and they just need something to kind of help them kind of ease into sleep, CBD can be a wonderful, non-addictive, low side effect risk for helping with sleep.
Thank you. Does carbamazepine, forgive me. Thank you. Thank you. Does that help with walking?
With what?
Can it help with walking?
So we typically use carbamazepine, which is an anticonvulsant medicine. The name brand is Tegretol. We typically use it for either neuropathic pain, so burning, hypersensitivity. It's one of the more commonly used drugs for trigeminal neuralgia or facial pain. So it wouldn't help walking directly. If it gets rid of your pain, if pain is limiting some of your walking, then it can help your walking indirectly. But we wouldn't typically think of it as something directly to improve walking.
And we have a couple of people asking if there's any cures coming in the future.
So again, we always like to take that question back a step and say, what do you mean by cure? Because I will guarantee you for people listening, it means different things to different people. If I'm the 25-year-old newly diagnosed person with no disability, I've had an attack and I'm diagnosed now, cure to that person probably means stop MS dead in its tracks. And I would argue with a lot of our more effective therapies, we can potentially do that right now. Your B cell therapies, your natalizumab, your Mavenclad type drugs really can be very effective at stopping MS. If I've been living with MS for a long while and I have mobility issues or other symptoms that appear to be permanent, I want to get rid of those symptoms. I want to eradicate disability. So those are two different kind of definitions of cure. I think with that second issue, neural repair or neuroplasticity, rerouting pathways to restore function, we're getting closer and closer. We're not there yet, but I really do think that will happen. I mean, there's so much research going on around the world into neural repair, and it's not just MS. For instance, the spinal cord injury, researchers around the world, if something works in spinal cord trauma, there's a decent chance it may work in MS also. Just a few weeks ago, the FDA gave expedited review status to a vagal nerve stimulator for potential neural repair. So vagal nerve stimulators are not new. They've been around for quite a while for managing refractory epilepsy, surgically implanted device that taps into the vagal nerve. But there is some indication that they may play a role in remyelination. So there's a large phase 3 study that's going on looking at vagal nerve stimulators to restore function in multiple sclerosis. What that designation from the FDA does is if the data look good, it should move through the red tape of the FDA more quickly because of the need that we have. We don't have anything that's FDA approved to repair damage. And so obviously if something looks great, we need to get that available to people as quickly as possible.
Thank you. And Mike, you have a couple of questions. One of them was any chance of this session being recorded or shared because they'd like to be able to go through it again and listen. And yes, in fact, in about 2 weeks, if not less, this will be on our YouTube channel and you can watch it as many times as you want. So, and I'll mention that again at the end. But also he said, is it possible to feel somewhat good, okay, besides leg problems, little to no pain? Is it possible to actually get to that?
Absolutely. I mean, people with MS are all over the map. And well, one of our physical therapists here at Shepherd Center, who just happens to be our CEO now, used to say, if you've seen one person with MS, you've seen one person with MS. It's like snowflakes, no two are identical. And so we see individuals that have very little symptoms. I mean, they feel great most of the time. And MS is really a very small part of their life. And then we see other individuals at the other end of the spectrum who are just, are dealing with pain and any number of symptoms. And then you'll see people who, their symptoms come and go. They have good days and bad days. So I think one of the important take-home messages is just make sure your MS healthcare team is aware of what's going on with you and, let them know what things are affecting your life. Chances are with most symptoms with MS, there's probably something available, whether it's physical therapy, medications, just some sort of therapeutic intervention. We want to be careful that we don't keep throwing drug after drug at somebody that we don't fall into what we call polypharmacy, or the person having a grocery sack full of medications. That we try to be thoughtful about medications and get rid of medications where we can. But yeah, make sure your healthcare team knows what's bugging you so that they can give you options.
And Kathleen has quite the lengthy question, and I am going to mess up one of the words, so you'll have to correct me. But she said she has relapse remitting MS and was diagnosed last December. Walking has improved since sudden HEMIPLEGIA.
Hemiplegia.
Thank you. Onset last June, and I am on Ocrevus, 71 years old. I can walk about 2 blocks with a cane without having to rest and have a pretty wide-based gait. I go to the gym 3 times weekly. What is your thought about 4-AP for someone like me?
So when she describes walking, and she says she's kind of fatiguing, she poops out. So that's called nerve fiber fatigue. So the areas of old damage in the brain or spinal cord where the myelin has been damaged, those areas work electrically, but they fatigue very quickly. She drains the battery. So she's walking, that nerve fiber where the damage has been eventually says, nope, I'm taking a break for a while. The person has to rest to cool off. That refractory period of how long they have to rest varies from person to person. So 4-aminopyridine, we would put into the same category as dalfampridine and then name brand Ampyra. These are all oral medications taken twice a day that work on potassium channels on naked nerve fibers or demyelinated nerve fibers. What we know is that they may improve electrical conduction and give you better endurance. They may improve walking by doing that. So 4-aminopyridine was the original version before there was any FDA approved version. It's made in compounding pharmacies, mom and pop pharmacies. There's typically no insurance coverage. It's a cost out of pocket. I'm using less 4-aminopyridine now that dalfampridine is generic. So our pharmacy here at Shepherd still compounds 4-aminopyridine, but really you could use dalfampridine, which the exact same mechanism of action. If your insurance company covers it, wonderful. You have very little cost out of pocket. If your insurance company doesn't cover it, you can go on Cost Plus, the online pharmacy. They have it for about $50 per month out of pocket. Usually that's going to be cheaper than what you would pay for 4-aminopyridine out of a compounding pharmacy. So any of those are fine. The response rate, again, is about 50-50. So if you try 4-aminopyridine or dalfampridine or Ampyra for a month, you're going to know if you're a responder or non-responder. And so just realize there's about a 50% chance you might not see benefit from it. But yeah, about 4 weeks is a good time to a good adequate trial of that. We don't want to use any of those medicines in someone with a history of epilepsy. You can increase seizure potential. We're a little nervous about using those medicines in someone with renal or kidney dysfunction because they are excreted through the kidneys. And if you're not able to excrete the drug, you may build up higher levels of it.
Is it normal for headaches to increase after 2 years of being on Kesimpta?
So we want to make sure the headaches aren't due to something else. There is head pain that can be associated with MS, things like trigeminal neuralgia or occipital neuralgia, pain in the back of the head. But a lot of times headaches are not related to MS. For instance, migraines are fairly common. Epidemiologically, a lot of people with MS have migraines. We don't think they're directly related. It's just that if you look at the primary risk group for MS, it's more women than men. If you look at the risk group for migraines, it's more women than men. So a lot of times it's just coincidental epidemiology that they overlap with each other. I wouldn't expect the Kesimpta to play a big role in the headaches. So I would look for other potential explanations for why that's going on.
Thank you. And RJ said he's a male that was first diagnosed with MS at age 63. So he's not sure when he first developed it. Is there any way for him to determine when he first got it?
Yeah, so we know that when a person is diagnosed with MS, that's probably not when things really started. That there is this prodrome that people, if you look at primary care doctor records, people with MS years and years before their diagnosis tend to have more primary care visits for things like fatigue and just not feeling well. So there's clearly there's something that leads up to it. There was research just published about a month ago, I think it was out of UC San Francisco, showing that about 10% of people with MS have this funny immune pattern of antibodies you can see in their blood work that was present years and years before they were actually diagnosed. The only way that we really could go back is if by some chance someone had an MRI for some reason, maybe they had a concussion, and we saw white matter lesions, typical for MS, or if in their medical records they went in and had symptoms that in retrospect were clearly related to their MS. Let's say they had optic neuritis and it just didn't get diagnosed, but in retrospect we know that that was a common manifestation of MS back then. But in some people, it's just not very easy to know exactly when it started. It's a big issue for veterans because there are financial implications of whether their MS is service connected. If a veteran has medical records and we can go back and show that when they were active duty or for within a few years after their separation from the military that they had clear indications that they were having MS symptoms back then, makes a big difference for them because it's a difference between being service connected for your MS or not.
Wow. Okay, what is loss of neural reserve?
So neural reserve is how much can I insult or injure my brain and spinal cord and get away with it? So with MS, you have way more white spots on your brain MRI than you do symptoms. Typically, for every MS relapse, there have been 5 to 10 lesions on MRI that have not caused any obvious symptoms. So somehow your brain adapted to that injury or insult to your brain, and you got away with it. Well, as we get older, we lose neural reserve. Our brain is not as able to adapt to those old injuries. So again, an MS lesion that was maybe giving you, a little bit of trouble walking or numbness or tingling. As we get older, maybe that MS lesion gives you more trouble, not that the lesion changed, but your brain's ability to adapt to that prior injury. And if you think outside of the MS world, probably one of the greatest examples of that would be post-polio syndrome. Someone who survived polio as a child maybe has a little bit of residual trouble walking from that polio as a child, but now as they get older, their walking is getting worse, not because they've had a new infection, but just because of that prior injury. As they get older, they're less able to adapt to that prior injury.
Thank you. Ree said that he has limited mobility and uses a rollator to get around. Recently switched to primary doctors, and the new one recommended that she see a bariatric physician for possible esophageal gastroplasty surgery and hopes to lose weight to help with increasing mobility. Any thoughts on this process? This person is overweight and wants to be able to exercise.
Yeah. So I do think that when people have obesity, it's just one more challenge to their walking. So I think it makes walking more difficult. It might make transfers more difficult. So if we can get someone closer to a healthy body weight, I do think it pays dividends in improved walking. How you do that is certainly open for discussion. We've had many individuals with MS have bariatric surgery, and people have done very well. So there's no contraindication to someone with MS having bariatric surgery. Right now, what we're seeing is a lot of individuals with MS who have obesity going on the Ozempic, Wegovy, that class of drugs, and those are working really well for a lot of our individuals. So I think there are different paths to weight loss. And bariatric surgery, if her healthcare team thinks that's appropriate, we certainly wouldn't have any reservations about someone doing that.
Perfect. Any questions on THC studies? Some say it's definitely something that helps, but this person does not partake.
So, where there's literature for THC helping in MS is really with spasms and spasticity. More the spasms probably than the spasticity. Central neuropathic pain, so burning, hypersensitivity, and then there is some evidence of benefit with overactive bladder type symptoms. We see people use cannabinoids to help get to sleep at night, whether that's CBD or THC products. It's enticing to think that cannabinoids might have anti-inflammatory effects that could change the course of MS. So every immune cell in our body has an endocannabinoid receptor. So clearly the cannabinoids do something in the immune system. No one's been able to show that in a study, though. We have no research to say that cannabis changes the long-term course. So we're not quite ready to say that cannabis should be a disease-modifying therapy, but for symptom management, I think it certainly is on the table for discussion. It gets challenging because every state has different laws, and I think we're gonna do a program soon. I think next month on update on cannabinoids and MS, and just talk about some of the challenges we see right now in terms of the products that are available and knowing what's safe and what's not safe.
Gus, thank you for telling us that Dr. Thrower and the staff is doing a great job, because I hope it's clear that we all love our jobs. And I think it shines. So I'm glad that you're recognizing that. Thank you. Thank you.
Thank you.
When you have MS, what can you take for flare-ups, especially when the weather is bad, like storms, rain, etc.?
So we want to make sure that we kind of make a distinction between true exacerbation. So when we say exacerbation, the other term would be relapse, attack. So the strict definition of a relapse or exacerbation or flare-up is a new or worsened neurological symptom that lasts at least 24 hours, and we don't have a better explanation. There are pseudo exacerbations or pseudo flare-ups. So this is, if the person has a viral infection, that's going to kind of rev up their immune system and make old symptoms act up. If a person gets overheated or exercises past a certain point, their symptoms might temporarily worsen a little bit. So we want to make sure that we know what we're dealing with. Is this true exacerbation or pseudo exacerbation, or maybe just baseline fluctuation of the symptoms? If a person is having a true exacerbation, what we know is that we can shorten the length of time that the person deals with those symptoms by using high-dose steroids. Typically in the United States, that's going to be 3 days of IV methylprednisolone or solumedrol, 1,000 milligrams a day. There is research out there that would suggest we can convert that to oral prednisone. It's a big dose of prednisone. We typically use 600 milligrams of prednisone for 3 days. There are places that would actually take that vial of IV solumedrol and actually put it into orange juice or something that's flavored and just have the person drink it. And there is evidence to show that can get into your system the same way as IV steroids. It's important for the person to know that the IV steroids don't change where you end up at. You will recover to the same degree with or without those steroids. We just get you there faster by doing the steroids. So in some ways, you could say the steroids are kind of a quality of life treatment. They're going to make you feel better faster. There are people who can't get steroids. They might have tightly controlled diabetes or really labile hypertension, or maybe they've had extreme mood reactions with steroids. We don't want those people to feel like they're going to change their ultimate recovery if they can't get steroids. Even if you have a relapse and you choose not to treat it with steroids, you still want your health care team to know about it so that we can document it, because the presence or absence of those relapses is going to factor into how effective we think your disease modifying therapy is in the long run.
Thank you. So, Christina said she was diagnosed at 62 years old in 2008, but recalled symptoms as far back as 30 years before. Just a curiosity about how MS works. When you have a relapse, then you reroute via neuroplasticity and have remission, then relapse again. Is that really how it works? After 30 years, since her symptoms are constant and don't go into remission anymore. She's just
Yeah.
curious how it works.
So all of those things can happen. So when you have a relapse and you get better, it could be that really nothing has changed. So we can conduct electrical information across a demyelinated nerve fiber. It works as long as you don't cut that nerve fiber. If it's demyelinated, it still works. It just doesn't work as effectively as it used to. And it is prone to that exercise or heat conduction block. So when you use it, it may shut down temporarily due to that sort of increase in core body temperature or heat. So one way that we can improve after a relapse is just by conduction across the naked nerve fiber. We do have the potential to remyelinate as humans. So why we don't do a better job of it is part of the mystery of MS, and hopefully one we'll solve soon. That neuroplasticity, that rerouting of pathways, we think is another way that you could get better after a relapse. We know that the more active a person is, and especially if we have a severe relapse, if we get the person involved in rehabilitation or exercise, there is evidence that might actually promote neuroplasticity and help those fibers reroute more effectively. So all of those things are ways that we can recover after a relapse. After every relapse, there's that 30% chance that you keep a little something. And then over time, maybe due to that smoldering inflammation on the surface, there may be this kind of, just accumulation of symptoms that don't go away. Maybe the loss of neural reserve is accounting for some of that accumulation of symptoms. I think one of the most misleading terms we've ever used in the MS world is relapsing remitting MS. When you say remitting, I hear I'm better, I'm symptom free. And when people are in remission with MS, it's pretty rare that they're symptom free. So most people with MS keep a little something, whether it's fatigue or bladder symptoms or walking issues, even when they're in remission.
Good point. Um, Lydia says that she was diagnosed with primary progressive in 2016. She has one brain lesion and a small number of spinal cord lesions. There's been no change with lesions. Her major symptom is muscle atrophy that started with right calf and worked its way up. She changed neurologist a year ago, and the new doctor said focal atrophy is not common for MS. Now, after a variety of tests, she's about to be diagnosed with a muscle disease. It makes me wonder, she says, if I have both diseases or if I do not have MS. Have you seen patients with both? Very confusing.
Yeah, that gets challenging. So we do have individuals who have two diagnoses. Primary progressive MS, is usually just this kind of slow progression of walking issues. We don't typically see focal atrophy, just one muscle group in MS, but you can see disuse atrophy. If you can't get the signal from brain to spinal cord to muscle, that muscle may get smaller just because it's not getting the electrical signal. And if it's so that is something we see. If it's really localized to the calf muscle, I would agree that's a little unusual for MS. So the calf muscle is the one that pushes your foot down. That's usually not what's weak in MS. Usually it's the muscle on the front of the leg that brings your foot up is where the most of the weakness is. So I agree that would be a little odd. Yeah, it does get challenging. So, with MS, we would expect to see these really hyperactive reflexes, maybe some of these abnormal reflexes like a Babinski, whereas we wouldn't see those things with a muscle disease. So, yeah, it is possible that she's dealing with two different things in the same person.
Thank you. Mike wants to know your opinion on the iconic sleeve.
So I think it's a great thing for foot drop. So really our three options for functional electrical stimulation for foot drop are the walk aid, the Bioness, and now the neural sleeve. We have a handful of individuals who are using them and are happy with it. The challenge we've had is it's kind of a practical, and what we would with those devices, we would love for you to work with a physical therapist and try it out to see if it does what you want it to do. The challenge with the neural sleeve is it's custom fit to your leg, so you have to buy it before you can try it. Then they do have a program where you can, you're not committed to the full payment for the device if it doesn't work for you. But it has been a little more challenging for physical therapists to work with because it's not like we have one sitting on the shelf that we can just put on you and let you try it out. You've got to kind of have it custom fit to your leg and buy it before we can use it. But it makes perfect sense. All these devices are, if we can't get the signal from brain to spinal cord to the peroneal nerve for your foot drop, we're just going to stimulate the nerve peripherally with this device, whether it's Bioness or the neural sleeve.
Thank you. We have just enough time for a couple more questions. And I'm sorry, everybody, there's a tremendous amount of questions that are going to go unanswered today. But I just want everyone to know that every single month we have a doctor doing a Q&A. And so you'll have the opportunity, whether it's waiting for 2 months from now for Dr. Thrower to do his, or doing it on the opposite month and having having a brain freeze. Aaron Boster. Yep, Aaron Boster doing his. Both of them are wonderful at answering questions, and I'm sorry that we can't get to everyone, but they're continually coming in, and you would be here all night. Your wife would be very angry you wouldn't come out for dinner. So anyway, but you do have an opportunity. Just check our website, and it'll indicate all the dates and the doctors that are speaking, and you can choose one of them to ask your questions. So let's see. I am 60 years old. I've been off meds for approximately 1.5 years due to a compromised immune system. I am seeing and feeling more progression, walking, bladder, bowel issues, and blurry left eye vision. Should I consider starting a new treatment? What do you feel about MS meds for people over 50?
So, usually we start having this discussion about maybe going off of a medicine. My age range was usually 60 to 65. The Disco MS study looked at 55 and up. So I don't know that we know that there's an absolute perfect number when you start having that discussion. If the person is progressing off of a DMT, are they progressing because we stopped the DMT, or are they progressing because of just the loss of neural reserve and this PIRA phenomenon, this progression independent of relapse activity? We haven't talked about neurofilament light chain. I mean, there is a blood test that we can do that sort of looks at breakdown of neurons. So neurofilament light chain is a protein that's released when neurons are being degraded. There is a thought that maybe we could use that to help determine kind of where someone's at in their MS kind of journey. The challenge with neurofilament light chain in our older population is neurofilament light chain levels do go up as we age. So I don't think we're quite as comfortable with our data on neurofilament light chain after age 55, but it is something we might think about. So let's say that that someone was on a DMT and you did a neurofilament light chain and the level was X, and we stopped the DMT and now it goes up. Well, that might be an indication that there is an underlying ongoing inflammation, and maybe we need to go back on a DMT. I think in her situation, having that discussion with her healthcare team, and maybe do you need to think about going back on a DMT, maybe one where there's not the potential for being immunocompromised. And what we end up using in a lot of situations like this is teriflunomide, just because it's a low level. That's not an immunosuppressant, but really doesn't compromise the immune system. We can use it safely in most individuals in this kind of situation.
And our last question, I can almost answer it myself, but I'm going to let you do it. Doris wants to know if Shepherd Center dispenses CBD.
So you don't have to come to Shepherd Center to buy. Our apothecary here does sell CBD. You can buy CBD in so many different places. So CBD is legal in all 50 states. It is a hemp-based product. By federal laws, CBD products cannot have more than 0.3% THC. So again, so many places you can buy really good high quality CBD. What I tell folks is, if you Google CBD store near me, you'll pull up 2 or 3 different places. Chances are within 10 miles of you. And again, lots of good high quality products out there.
Thank you. And that does bring us to the end of our time. And if you've missed any part of this conference, it has been recorded, as I mentioned, and will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access the recordings, or just sign up for your newsletter, our newsletter, to learn more about the upcoming events. Our next teleconference is going to be Monday, this coming Monday, May 20th at 3:00 p.m. Eastern. Tiffany Malone, who's not only a Master's of Social Work, but also an MS certified specialist, will be discussing the importance of self-care for people living with MS. As you leave the conference today, please, you're going to notice that a survey is appearing on your screen. We ask that you please take just a moment to give us your feedback on the program and your suggestions for future topics. This way, we'll be able to provide you with the best programs possible and the ones that are most meaningful to you. So our sincere thanks to all of our attendees for your participation, and especially to Dr. Thrower for once again astounding us with your vast knowledge and your willingness to answer everyone's questions. So have a wonderful evening, everybody, and we hope to see you again. Bye.
Thank you, everybody.